Tammy McCausland bringing you SROA SoundBoard. I'm joined today by Dr. Bisham Chera, Associate Chair of Clinical Operations and Improvement and Director of Patient Safety and Quality in the Department of Radiation Oncology at the University of North Carolina School of Medicine. We're speaking about radiation oncology in the time of the pandemic. Welcome, Dr. Chera.
What actions did your facility take, and what has been the hardest since the coronavirus cold?
Yeah, so in our department, like many other radiation oncology departments, what we've done is try to have as many staff members work remotely from home as possible. And what that means is that, you know, if you can work from home, we want you to work from home, and that's all staff. Now, it's really hard for our therapists to do that, obviously, because they are frontline workers treating patients. Another thing that we've done is, try to do more physical distancing even at work. And all of our conferences are remote, WebEx, where we're all in our offices, but we're all dialed in. And also when we're working in the clinics, we try to practice physical distancing between ourselves. We've moved to more telehealth work for our patients, so doing more televisits. That's the telephone calls and also video visits. With the government deregulating this now, it's allowed us to do more of this, and this reduces the goal is to reduce the number of patients coming through our clinic to minimize them being exposed, and also to create physical distancing for the patients and the providers. And so I think that's going to be that's going to change the way medicine is practiced. And I think going after the COVID-19 epidemic, this telehealth is going to be a main part of medical care for patients in the United States.
And what about the patients when they actually have to come for treatment? What kind of measures are you taking, and what have you been telling the patients to do either before they arrive and after they leave?
Yeah, so we are and this is standard practice among all clinics, is to screen patients. So our admin staff, when they call patients, for the few that come in for follow-ups or consults, they're screened on the phone, with a set of hospital administration approved screening questions to try to see if they may be at risk of having COVID. So they get screened before their visit, the day before or a couple of days before. When they come to check in, our front desk staff has set up physical barriers to create physical distancing between the front desk staff and the patient checking in, about at least 6 feet. But front desk staff also screen them with the same questions. For patients who are on treatment, what we do is that our therapist every day screen the patients with questions. And the screening question changes every week, or even sooner, faster than that. One day it's fever is the screening question, and then the next day it's not. So we've been trying to keep up with the hospital guidelines. So there's a lot of screening screening with questions. And if a patient is positive per the screening question, then there's a whole procedure of, getting the patient tested for COVID-19. So if a patient screens positive and they're at home, meaning they call in, is coming in for visit and they screen positive by the admin person gives them a COVID-19 hotline to call, which is run by our UNC hospital systems. And there's someone who does a telehealth visit with them and determines whether the patient needs to stay at home or come into our drive-through COVID-19 testing. If a patient's in clinic and they screen positive, they immediately get put into an isolation room, given a mask, and we call infection control, or we also can get them over to get tested for COVID-19 at our walk-in facility.
Have you had any patients test positive?
We have not. We've had several patients who screen positive to the question, and then they have a COVID-19 test done, and they're a person under investigation. And we've had several of those kind of patients where they're on treatment or they're about to start treatment, and they have to have a COVID-19 test performed, And usually the test result comes back in 24 to 48 hours, but it depends on who's doing the testing. Sometimes it can take up to 2 weeks. So once a patient is identified as, possible COVID-19 infection and then get this test, we tell the patient that we're not able to, per hospital policy, treat you or have you come into the clinic until we get the test result. So we've had several patients had to have their radiation delayed somewhat, but they had to go on a radiation break for a couple of days while we awaited the COVID-19 results to come back. So far, they've always been negative, and we're able to resume treatment for these patients.
What about the facilities themselves in terms of the physical keeping, if you have a patient that's been on the table, what kind of sanitization practices are you using to make sure, just in case somebody may have been exposed to COVID and they don't show symptoms?
Yeah, so even before this COVID-19 issue, our it's standard practice for our therapist in the vault to wipe down treatment devices and the table couch top with sanitizing wipes that specifically disinfect for SARS and other viruses and bacteria. And in fact, I actually went and checked all these wipes and saw what they looked at their labels, and the labels say that it does disinfect for coronavirus and SARS. So even before we had this issue, our therapists were doing this standardly. Since the coronavirus epidemic has occurred, or pandemic rather, we have just reinforced, strict sanitization in between patients, and the big issue is that, we would love for our frontline staff to have, masks, surgical masks to wear every day, but currently with the low supply of the personal protective equipment, and also, in radiation oncology, we are not a high-risk clinic for having a lot of patients come in with COVID. We don't have the supplies to give our therapists to wear a mask every day.
So what are you telling the staff that you wish you could give those supplies to, but you can't because of the shortage?
Yeah, I mean, they're screening they're screening patients with questions, and so hopefully that will help them identify patients sooner rather than later at possibly having the COVID-19 infection. We are, we've reinforced, proper policy and procedure with taking care of patients. We continue to advocate at the hospital level that, once personal protective equipment is available and if there's enough supply, we want to have that for our staff, our nurses, or our therapists. I mean, it's somewhat controversial depending on who you talk to, whether masks are protective or not, but it appears that there may be some protection and also prevention of spreading the virus if you're a carrier and asymptomatic. Something else that we've done is that we've instructed every treatment patient about the coronavirus and what they need to be looking for, what they should be doing. So in our on-treatment status checks, I know I do it and my colleagues do it, we educate the patient almost every status check, and we talk about the virus and the fact that they are somewhat immunocompromised, so they have a higher risk of getting the infection. And if they get the infection because they're immunocompromised and our cancer patient may have a higher risk of a complication, a bad outcome rather from the virus, meaning a higher chance of being intubated or dying or being hospitalized. And so we also, and part of that education is we tell them, if you develop cold-like symptoms, do not come in, give us a call, and we will triage you to the right clinic or to get tested for COVID-19. We tell them not to go to the ER. We say, give us a call, don't come in, and we'll work with you over the phone to get you tested or whatever needs to be done.
You mentioned at the beginning that more delivery of services through telehealth is going to change the way medicine is practiced even after the pandemic. Could you elaborate a little bit on why you think that is the case and how it will change?
Yeah, I think access to care is always been an issue. So, with the deregulation and the loosening of and deregulation, not in a bad way. I mean, they've removed a lot of red tape so that we can do this more freely and more readily for patients. So I think what's going to happen is that, patients are going to be able to get more specialty consultations, without having to, come in and drive 4 or 5 hours. So I think that they'll get better consultative services. Also, I think in surveillance, the cost of cancer care is expensive, but a good chunk of the cost comes from surveillance, following patients after treatment and all the visits and the imaging studies and whatnot, laboratory studies. And I can definitely see for patients who, have projected excellent outcomes after treatment, and patients who also have known to have minimal long-term side effects, depending on their cancer and type of treatment. Those patients could be surveilled and monitored through telehealth. I'm gonna propose that, for that low risk, for that prostate cancer patient who's, in follow-up, really the major thing in follow-up is to check the PSA. So, you could easily get your PSA done locally, and you could, have a telehealth visit for survivorship issues. And so I think that maybe it'll improve patients' compliance with follow-up. It'll reduce the cost of follow-up, better access to good surveillance follow-up care. And, the diagnostic world is changing so quickly, where there's a lot more blood-based biomarkers that are being developed. For example, circulating tumor HPV DNA can be used to detect cancer recurrence. So you can imagine that, oropharynx cancer patient who received chemoradiation, 5 years out, they still need to be seen, but, they can get the blood test done locally and have a televisit for survivorship care issues over the phone or through the video.
Is the pandemic also going to change the way we look at patient safety and quality in radiation oncology?
Our profession is by nature more. It's easier for us to be focused on quality and safety. Part of it because of the engineering kindness of fashion of our work, and so I think our specialties does naturally focus on that. And with this coronavirus pandemic, how has it changed what we do? I think that we will continue to focus on quality and safety. It's definitely made us more attuned to infection control things and issues. But I think that we will continue to have a strong interest in focusing on quality and safety even after all of this.
Last question. What advice would you have for other radiation oncology administrators and other staff that are involved in radiation oncology to help get through this pandemic?
Yeah, this is obviously a very challenging time, and for a hospital administrator, you have to worry about keeping your staff healthy and safe and keeping the patients healthy and safe. And in this time, it's hard to plan for what you don't know what's going to happen, the unexpected. The number of COVID emails that I get in a day is pretty astonishing, and as an administrator, I'm sure that they get like twice as many as I do. Planning for having a quarter of your staff, one day you show up one day and get told that there was a COVID-19 patient that we didn't know about, and occupational health or infection control says that a quarter of your staff has to be quarantined for 2 weeks. Those are the kind of things that, as an administrator, you got to treat the patients. You got to have staff to do it. How do you plan ahead for these possible disaster situations? Trying to get people to work remotely. I know people have done creative things. We'll have a team A, team B that never see each other in the department. The team A comes in, and then team B comes in, but team B and team A don't interact to minimize, transferring and getting infected or exposed. I've heard of departments basically kind of setting up a Noah's Ark, where 3 weeks ago they picked 2 physicists and 2 physicians, a couple therapists, dosimetrists, a small selection of everybody from every division of the department, and they said, you guys don't even come to work. Work remotely, never come in, And we're doing this just in case that all of us get sick. Then we'll at least have a backup team to come in. So there's a lot of people doing a lot of creative stuff. But I think that from an administrative side, one of the hardest things to plan for, but should be planned for, is, you walk in one day and get told by someone, a regulator, a quarter of your staff can't come in for 2 weeks.
Thanks for those examples. It was a pleasure talking to you today. Really appreciate your time.